All righty. Welcome. So, we got another installment of some lecture here. I thought we'd go over the physiology just briefly, nothing too crazy, no super depth into these systems, but just a good overview, basic understanding of the function. And then, of course, go into pathology mostly is what our focus will be of each individual system. This will more than likely be a two-parter video because there's lots of pathologies for us to go over. So I'm going to cap our session here to end at 8:30. If you have questions during the video, feel free to chime in, let me know, pause me. If you're watching the recording, then, just feel free to email, get some clarification on things. So let's go ahead and get into it. Can everyone hear me?
I can hear you.
Oh, okay. I don't know. That's on your end. I'm sorry. Yes, sir. Dude. Right now. You're on Candy Camera, man. And feel free to have a seat if you want. Okay. All right. So let's go ahead and crack into it. So first up is the skeletal system. Let's take a look at the functionality of the skeletal system in itself. So first, our bones, as you may automatically assume, provide support, right? Our essential shape of our body is depicted by bones to an extent, right? So like our entire face, right, is all bones, right? It gives us that shape, right? Of course, these bones also protect our vital organs, right? Our skull will encase our brain and protect that, as well as our rib cage houses the lungs, and the heart protects those as well. Now, the skeletal system is a component in what we call the locomotive system, which with the help of the muscular system and the nervous system, we provide movement. So the bones, in a sense, act as levers, and the muscles act as pulleys. And so the muscles attach to the skeletal frame, and then the nervous system tells those muscles to contract. And when those muscles contract, well, they pivot bones around each other to create the movements. So blood cell production is produced in larger bones in later life, and such as the femur and our humerus, mostly the femur. And we find that to be produced in the red bone marrow of the larger bones, which is in the hollow medullary cavity of the long bone. So as well as in that medullary cavity, we also store yellow bone marrow, which is fat and other minerals and nutrients as well, which is why our animals, our dogs, which I don't have dogs, but maybe you do, have such a liking to eat bones or chew bones, because all the little minerals in there, little fat, delicious. No. And then lastly, of course, it has mineral storage. So the bones themselves are composed of numerous minerals, one of which being calcium, right? That's a pretty given one. And so we can break down bones to release minerals and so on and so forth into the body. So just a good understanding of our skeletal system. And honestly, with new science emerging, your skeletal system is really crazy and phenomenal. And we're actually linking it to, part of the sympathetic response. And so, we talk about the adrenal glands kicking in to, engage us for fight or flight. But they're actually seeing that bones play a type of role in that sympathetic response too. So it's pretty neat stuff. Stay tuned, more information. So let's go ahead and look at some pathologies related to the skeletal system, joints in general, and related structures like the ligaments and stuff like that. So our first one up is the technical term for adhesive capsulitis. So adhesive capsulitis, in a simplified layman's term, is frozen shoulder, right? And so frozen shoulder might sound pretty straightforward, right? A shoulder, right? We know what a shoulder is. It's frozen. Well, something's frozen. It's stiff and not moving. It looks like the meme from the Game of Thrones. So if we actually break down the technical word adhesive capsulitis, well, adhesive, like a glue, sticks things together, stuck, right? Capsulitis, well, we break that down. One, we see itis. We all know what itis is, hopefully at this point, which is inflammation. And then capsule, which, well, all joints have a capsule. So this is inflammation of the joint capsule, specifically of the shoulder, that causes restrictions in movements, right? So there are lots of possible causes for adhesive capsulitis. And without getting into too much detail, some of your basic instances of adhesive capsulitis could be, well, sometimes it's just idiopathic meaning that there's no real known onset. Sometimes they call it 40-year-old shoulder. And so one day you just like your shoulder's stuck and then like, well, there you go, right? It's a frozen shoulder. So other instances could be, well, if you had an injury to the area and especially in a sense, like it was in a sling and the, area was immobile, there could be several causes in that regard, as well as there could have been some sort of damage and infection even into the joint itself. So let's go into that instance where the joint is immobile, right? So immobility, right? If something is sitting in its place for so long, it's hard for it to start moving again. Think like you just binged, your favorite TV show for 6, 7, 8 hours, and all of a sudden you try to peel yourself off the couch. You ain't moving too fast. You ain't moving so good. Same thing for a shoulder, right? If it's been in a cast or a sling for 2-3 weeks, movement will be restricted, right? Other possible causes could be the opposite end of that spectrum, which would be overuse, right? Or repetitive use. So moving the shoulder, working overhead and doing all these crazy movements could create inflammation in the capsule and then lead to stiffening and restrictions in movement. So what can massage do in most and all of these instances? Well, massage can actually be quite beneficial in some of the causes. So of course, if there's present inflammation, if there is an infection, if there is injury to the joint capsule, then it's probably best to just leave it alone until it's healed well enough to then we can come in and start imparting our massage and be more restorative, recuperative, rehabilitative. So if, for instance, the frozen shoulder, if the mobility is limited because of the fact that it hasn't been moving a lot, so basically inactivity, so it was in that sling for quite some time, well, one of the better things to do is to slowly integrate movement and range of motion. So of course it's not just taking their arm and going but slowly integrating movement, range of motion exercises would be beneficial. And then of course on the opposite end, right, if the onset was because that it was overactive, then you'd want to focus more on just letting the joint rest, heal, and not be active in a sense. That's all I can pretty much imagine to say about frozen shoulder in its simplest sense. Is it an absolute contraindication? No. Can it be a local contraindication? In some instances, yes. But can massage actually help this condition? In many cases, yes. So, depending on your health intake, might depict on your approach to what you're going to do with your client in regards to the condition. So our next one up, and these are all in your textbook as well. You'll find them in the end of each chapter, so you can follow along in the textbook as well. And so the textbook is nice where, it tells you, good understandings of the condition itself, and then gives you the what massage can or can't do, and considerations around that. So our next condition up is called a Baker cyst. So a Baker cyst is an accumulation of fluid, synovial fluid, behind the knee in the popliteal region. So now, most of the time, this can be caused because of some sort of injury in the knee itself. So something about the torn cartilage, could be, one of the ligament tears as well. Some sort of damage might be present in the knee. So with that being the case, you would obviously think with fluid or swelling in the area, then lymphatic drainage, which in some cases maybe, but for the most part, we're going to be leaving this alone and just avoiding the popliteal region, the back of the knee, which we pretty much do anyways. So not too big of a concern. So here we have a local contraindication, not an absolute contraindication. Bursitis is a general term. Bursitis, if we break this word down, itis again, right? We see that inflammation. Bursa, well, what is a bursa? A bursa is a pouch or a sac that is filled with synovial fluid. And what do bursas do? Well, bursas are found around joints, and they typically cushion around the joints, especially around the tendons. So like tendons might lay on this little cushion like a pillow so that it doesn't wear and tear and, get irritated by sliding over a bone. Instead, it slides over a nice soft cushion. So in some cases, the bursa itself can become inflamed, swollen, stiff, so on and so forth, especially in very mobile areas of the body. So what do we do for bursitis? Well, one, we don't massage bursas to begin with, so not much to do, right? Not much to do in the sense of alleviating or treating the condition itself, but we could be more palliative and help to reduce the pain and suffering maybe because of this, right? So remember, palliative care is that pain and suffering care where we're providing a level of care to ease people's pain and discomfort, where that what we're doing isn't going to make them better. They just feel better and kind of forget that there's a problem. So in this case, that's what we would be doing with bursitis. We would just be essentially just, working very generally and just trying to aim to reduce their pain and discomfort. Now, of course, if the bursitis is really severe, and even back to the Baker cyst as well, if there's indications that they have systemic infection or like a fever or something like that, if ever inflammation is systemic and affecting the entire body, that's cause for concern, and that could be an absolute contraindication. Bursitis more than likely would never get that severe. Baker cysts possibly could, but the bursitis, shouldn't get to that point. But if it's so severe that they can't move the area, or it just hurts to work in the area itself, then just treat it as a local contraindication and avoid the area altogether. Our next pathologies up are luxations and subluxations. So what is a luxation? Well, it sounds luxurious, sounds like a vacation, but it's terrible. It'd be very hard to deal with and very annoying, and ouch, just so painful. So a luxation in itself is the technical term for a dislocated joint. And then a subluxation, which I've heard many chiropractors and experts say how, subluxations are kind of misnomers, because if a subluxation is present, then it's technically just luxated. It's dislocated, right? But anyways, a subluxation is what we would call a partial dislocation of the joint itself. So if you look at the picture there, you can see where the subluxation, I mean, that's pretty dislocated in my opinion, right? But as you can see, the luxation where it's just nowhere near attachment areas or something, but whatever. Needless to say, what do we do with a dislocation? Well, one, are they walking in with that dislocation? Because if so, then I'm not going to work that area, right? That's an absolute local, well, sorry, I use both terms. It's just a local contraindication. I would totally avoid that area. Absolutely. So you avoid that area. Now, let's say that they've dislocated a joint numerous times in their lifetime, and especially if that joint is susceptible to location or dislocations in itself, right? So what do we do in that case? Well, if they have habitually dislocated a specific joint and that joint is prone to being dislocated, that means the structures are very, they're not very integrated. They're not very strong. They're not very sturdy. You know, that we want to be considerate of how we would move that joint to the point where I would be very reluctant to actually perform any range of motion exercises, especially any traction exercises. Remember, traction is where you pull on a joint or a structure, right, producing tensile force. So I would absolutely avoid traction, and I'd be very, 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 very careful and almost avoid completely the stretching of the joint if they've had habitual repeat luxations in the area. Gout, so also known as king's toe, the plague of kings. Ah, my big toe. Or as you might think, maybe a good old granny. She got her bunions and her big toe just hurting. She wants you to rub that big toe. Well, what is gout? So gout itself is characterized by uric acid crystallizations that deposit in the joint. So specifically, it mostly affects the big toe, the first toe, right? The metatarsophalangeal joint of the first digit, more technical. So think like these little acid crystals are almost like grains of sand, and these grains of sand embed in the joint itself. Just think like how sometimes you have sand in your butt crack and just moving around bothers and irritates it. Well, imagine grains of sand in a joint. Whoo, ouch, that hurts, right? So, and it can affect other joints. Just most commonly, it's the big toe, but it's possible to affect other joints. So what exactly happens, or how is this caused? Well, typically, it's mostly caused because of diet. You know, so typically high fatty meat-based diets will typically lead to gout, especially seafoods too, I believe, are also a big causer as well. Alcohol consumption, and then, you know, there's tons of other causes even outside of that. So what do we do for gout? Well, one, if it's extremely painful, if ever your client has pain and discomfort, especially while getting massaged in that area, then you avoid massaging that area, or avoid the massage entirely. If, like, I don't know, if I'm massaging the scalp and their big toe is just throbbing to the point where they just can't deal with it, then I'll just stop the massage, right? But you know, in some cases, a little bit of massage around the area could be palliative, as we just mentioned, right? And, you know, bring that sense of ease and discomfort, right? Especially in that grandma edition, you know, rubbing grandma's bunions. Come on, child, rub these little bunions. So sometimes, you know, working in the area might be beneficial, and but for the most part, you might just want to leave it alone. So really, it's in your client's court. You put the ball in their court of, you know, how you'd want to approach. So some people might want you to massage it. Some people might want you to leave it completely alone. So it's really up to the client and, level of comfort. But am I too much sometimes? Miss Guerrero? Must be new people's. All right, our next person, kyphosis. Kyphosis. So what is kyphosis? I highly implore you all to make sure that you understand kyphosis, especially I think the next couple slides are going to be the major postural deviations of the spine: kyphosis, lordosis, scoliosis, right? It's like the trinity of back postural abnormalities, right? And we definitely want to know what to do and how to consider working with all of these conditions. No, this is not. This is if you've literally just started this program and you're joining in thinking this is going to help you right now, it's not going to help you right now, but in the future it will. So this is more of like end of game kind of situation for most people, people who are, nearing taking their final. This is more of like an overall recap of bigger parts of the program. So if anyone is brand new to the program right now, maybe just save this video for later. But anyways, kyphosis. Actually, I do think the first few modules might talk about kyphosis and lordosis. So hey, you never know. It's all peppered in there, but not specifically about the first modules or anything. Anyways, so kyphosis is what we call hunchback, right? That's the more layman term. So if you look at the picture here, you can see that on one side we have a normal spine, which is relatively straight. Yeah, not perfectly straight. Shouldn't be perfectly straight. Be right back. Right. So your natural spine does have curves, and of those curves, we have lordotic curves and kyphotic curves. So a lordotic curve is a curve that points this way. So your lumbar region, low back, is a lordotic curve. A kyphotic curve points posteriorly or backwards. So kyphotic curve in the thoracic region. So kyphosis, if we break that word down, osis means the condition of. And so this is the condition of having an excessive kyphotic curvature. So sometimes we call this hyperkyphosis as well, because hyper means excessive, kypho, right, referring to the kyphotic curve, osis, the condition of, right? So that's where a lot of your pathologies come from, is just breaking down these words and knowing the language of anatomy and physiology, which is in that first lecture. So if my normal posture, my normal state of the kyphotic curve here should be this much bowed. Well, if I have kyphosis, then it's like that, right? It's really hunchback, right? Think about that 90-year-old lady in the supermarket, and she's just walking by, looking at the bananas. And you just sit behind her like, move! But don't do that, because she's a sweet old lady. And we'll be there one day. So what exactly is going on with this kyphosis? Well, it just happens, right? A lot of times in a lot of these conditions, you just have it just because of the structures of your body, right? So there's nothing we really do in this case but make you comfortable. Now, sometimes it can be caused because of your own posture or other structures that are causing this position to be adopted. So let's just take a look first at how we would make a client with kyphosis comfortable. So you would imagine that if I had a really rounded upper back, if I tried to lay flat, well, look at where my neck would be, right? It would be very uncomfortable, and I would have all this pressure right here on the apex of the curve of the spine, of the kyphotic curvature of the spine. So if my client is laying face up, what should I do? Well, I would really and ideally bolster the upper back, neck, shoulders, right? And that would hopefully ease the discomfort of my client lying supine. So what about face down? Well, face down usually won't have a whole lot of discomfort, but you could prop up the shoulders, right? And that'll especially lead us into, well, what would we consider in a massage sense to help with kyphosis itself? So sometimes kyphosis can cause other postural abnormalities or other postural deviations, one of which is what we call rounded shoulders. More technical is upper cross syndrome, which means that my shoulder, if instead of pointing straight, it's turned in. So I look like this. So one possible cause of kyphosis could be just posture in general, right? So imagine being slumped over at a computer desk like this all day, right? And never straightening out. Well, what's happening? Well, my shoulders are internally rotated, turned in, upper cross syndrome. My chest muscles, my pectoralis muscles are tight and pulled forward, and pulling my shoulders forward, right? So what could I do to help alleviate kyphosis in a sense of postural correction and muscular release? Well, I would want to release the anterior muscles of the shoulder, right? The muscles in the front. I would want to release the pecs. I'd want to release the the anterior delts. I'd want to release the subscapularis for internal rotation of the shoulder, right? And then, of course, I'd want to strengthen my upper back muscles, right? Namely, like the rhomboids, the trapezius muscle, the external rotators, like the teres minor, teres minor, infraspinatus, yeah, and even the lats and teres major. Why not, right? So, and you're going to see a lot of people come to you because of this, right? You're going to see a lot of people and they look like this and they're like, my upper back hurts, but they're like this, right? So let me say this, right? That a lot of times, but not always, a lot of times where our client is feeling pain and discomfort, it is not the source of the pain, right? It's a symptom. What do I mean there? Pain, the source versus the symptom, right? Well, the source is the main reason that the pain is being caused, and the pain is the symptom, right? So muscles themselves, they don't necessarily mind too much being in a shortened state, right? What they don't like is being rapidly stretched out from that shortened state or being stretched out for long periods of time. So my pec muscles, my anterior delts, and all these other muscles on the front of my upper body are tight and short. They're happy. They don't care, right? But my upper back muscles, like my rhomboids and trapezius, they're literally trying to grab and hold these shoulder blades from going forward. So it's literally like the strongman exercise where you're grabbing two things like, oh, you got the rhomboids sneezing out, trying to hold these massive shoulder blades from being stuck forward, right? Of course, they're going to feel pain and discomfort, right? Because they're not, in a proper position. So it's very common that your clients will come in with upper cross syndrome, maybe not necessarily kyphosis, but upper cross syndrome, tight upper body, tight anterior upper body, and complain about back pain. And it's just more than likely not the cause. It's not always a given, but it's possible, right? So I know we tangented a lot, especially with these conditions, because these are the very main conditions that are going to be really big for your understanding of, keeping clients comfortable and, general massage knowledge that you need to have, because this is a pretty common condition to see clients coming in with: kyphosis, lordosis, scoliosis, all these little deviations of the spine. So let's just briefly recap what we said about kyphosis, which is one, kyphosis is the technical term for hunchback, which is an excessive curvature in the upper back, right? So my hunchback leans back. Now, this could be caused because of just your body being that way, or potential postural causes such as tight muscles, the way you sit, the way you hold yourself, right? Now, in all cases, our goal is to make our client comfortable. And that would include that if my client is lying face up or supine, that I would prop up the upper back, neck, shoulders and keep them comfortable. If they're laying face down, I may want to cushion the chest and shoulders as well. Then, of course, on a more corrective side, if this is caused because of tight muscles and just your general posture being, off, then we can, try to release the tight muscles in the anterior upper body, as well as, big part on their part, right? Because massage can only do so much, right? We can't tell them to do all these different exercises and things like this, and that's one of the big downsides, right? Is that a lot of times these conditions that people come in with, they can be easily fixed with a little bit of massage, a little bit of personal training, right? And just conscious effort on their part, but they don't want to do any of that, really. So don't be upset that you keep getting this client coming back to you and the same thing's there, because they don't do anything about it. They just come to you for the massage, makes them feel better for a little bit, and then they keep coming back. Hey, money in your pocket, right? What are you gonna do? Tangent. Oh man, I'm getting heated, getting furious up in my feels about things. But anyways, if you have any questions on kyphosis, let me know. Lordosis, as I thought, would be the next one. So lordosis, pretty much the exact same thing as kyphosis, except it's the lordotic curvature that is excessive. So in this case, your low back is excessively curved. I like to call this booty pop syndrome because it goes boop. Now, there are different types of lordosis, as you can see in this picture. We have what's known as sway back, where as you can see, the hips are more pointed forward, but there's still a lordotic curvature. And then, of course, we have, just the normal, in a sense, what we perceive to be lordosis to be, which I like to call the booty pop syndrome, because that booty just stick out. That's that club syndrome where they be twerking that thing, right? So what's going on? Well, again, one, you could have just been born like this, and there's nothing to do besides make a client comfortable. Of course, there also could be, on the flip side, postural reasons and muscular reasons related to this as well. So let's break it down a little bit further. I might need to grab a couple more bones from my bone box. You got a bone box, right? Everyone should have a bone box. And they're usually filled with the bones of my victims. I think this guy will do right here. All right, so hopefully, trying to see what you guys can see. What we have here is a pelvis, right? Here's your sacrum. Here's one wing of the pelvis, and then here's your femur. Of course, we don't have the lumbar part of the spine here, but hopefully you'll see what I'm trying to portray for you. But so what's happening with lordosis? Well, one, the lumbar curve is bowing forward. And now this causes other things to happen. So if the lumbar curve goes forward, then so does, because your sacrum is an extension of the spine, it's part of the spine, right? The sacrum also bows back along with it, right? You see how that happened? Well, of course, my sacrum is connected to my hips, to my pelvis, right? So if the sacrum right here starts turning back, well, look what happened to my pelvis. My pelvis anteriorly rotated. What is an anterior tilt of the pelvis? An anterior tilt of the pelvis is where your pelvis, so this is my pelvis forward, like if I was standing, you were looking at my pelvis down here, right? This is my pelvis. It leans forward, it tilts forward like it's bowing, because it's Japanese and it's very formal bows, right? So we have this pelvis that starts tilting forward, this anterior tilt. Well, what happens now? Now the femur starts to compensate, right? And then it has to come forward as well. So you have all these little postural things going on, right? In the lumbopelvic hip complex, right? So what are we doing? Well, one, first and foremost, always just keep your client comfortable. What do you do for a client? Well, if they are laying face up, right? So if your client is supine and they have this typical lumbar lordosis, then I want to bolster, ideally and primarily, the knees, right? So why is that? Well, if you notice, right, so if I'm laying, if my lumbar, if my spine is like this, right? I'm trying to make this right. Okay, maybe I'll do this, right? So if I'm laying face down, right, and this is my low back, well, this also means that my hips are tilted this way and that my pelvis is tilted this way, my hips are laying flat. But if I actually prop my legs up, my knees up, and bend my knees, it actually rotates my pelvis posteriorly, which then helps to alleviate or reduce the amount of curvature in the low back, right? So first and foremost, I would want to prop the knees as high as comfortably possible to reduce the curvature in the low back while they're laying supine. And even better would be if I could add in propping up the low back as well. Why not, right? Knees and low back, but knees will take precedence. I mean, you already bolster someone's knees when they're face up in supine, right? So there you go. So when they're laying face down, so now they're like this, right? They're looking like a breached whale. Then I want to bolster the hips. I'd like to bolster the hips, right? Because that's going to, if I put a cushion, you see how that happened? If I put a cushion under their hips, it's just boom. It tilts those hips back a little bit and levels out the spine a little bit more. So that could make their life a whole lot more comfortable. Now, what's happening with lordosis if we have muscular-related issues? Well, what would be tight? Well, we can get into the real nitty-gritty of like interspinal muscles, paraspinal muscles, all that good stuff, right? But your hip flexors would be pretty tight being in this position. So, stretching out hip flexors could be beneficial. Your low back muscles in general could be tight and causing that. So they might have issues with the hips. They might have issues with the low back. Your hamstrings would be stretched out. Your abdominal muscles would be stretched out. So it's all just like this interplay and thinking of like, well, if I'm in this position based off of what muscles touch and go through this area, what's tight, what's short, right? So essentially you have, whenever we have, tilting of the pelvis, there's this very complex marionette, dynamic of what muscles are tilting, the pelvis this way. You got muscles on the back pulling it up like this, and then muscles on the back down here pulling it like that. You got muscles on the front up here going like doop, and then you got muscles down here going doop, right? It's pretty complex. I don't want to go too crazy with it, even though I'm already going crazy. It's been like 45 minutes, we ain't even on the first, out of the first physiology. But anyways, Lordosis, osteoarthritis, almost was the scoliosis. It might be the next slide or two. Actually, I think they're in alphabetical order, so whatever. Anyways, all right, so what is osteoarthritis? Osteoarthritis is a pretty general condition, all acronymed OA, which we can just basically call arthritis, right? So whenever time we talk about like someone who has arthritis, right, we're typically talking about osteoarthritis, which is also known as wear and tear arthritis. So basically, this is just usually occurs because of old age or excessive usage of the joint itself, right? So what is happening? Well, as you can see in this picture, there's this like purplish blue stuff on these bones, right? And this happens to be a knee joint. This purplish blue stuff is what's called hyaline cartilage. It's also known as articular cartilage. It's the cartilage that's on the parts of bones where the two bones come together and touch. Everyone's seen this if you've eaten chicken wings before, or chicken in itself, right? And you take that drumstick and you eat it up, and on the knobs of the drumstick are those little pearly white bits. Most people call it the gristle, right? That is hyaline cartilage. That cartilage helps to reduce the friction and wear and tear between the bones as the joint moves. So what happens is that, well, that cartilage starts to wear down over time and then creates inflammation in the area and potentially creates, bone-on-bone contact and friction in the area, which then just leads to the pain and everything. So arthritis, what do we do as massage therapists for arthritis? Well, if the joint hurts to move, try not to move it a lot, right? I'd be very reserved with my range of motion exercises, but general work around the joint can be very palliative and ease the pain that the client might be experiencing because of this condition. Osteoporosis. Well, you probably heard of that, right? Probably heard about some old lady who has osteoporosis and bones. Well, if we break that word down, let's take a look. Os means bone. Porosis, or think pore, like porous, right? And then osis is the condition of. So this is the condition of having porous bone. Well, what is porous, if you've never heard that term before? Porous means that there's like pockets, or that there is space and air pockets and whatever present in there. So think like a sponge is porous, right? And it can absorb that moisture, right? So in this case, in reference to the bones, this means that there's less density to the bones. The bone is much more brittle and weaker. So this condition is typically caused because of calcium deficiencies and so on. That leads to weaker bones. It's usually caused from old age. It can also be caused because of a sedentary lifestyle. Now, the reason why we typically associate this with older women is that, and I believe firmly that this paradigm would change with, the fact that, that life is so much more different today than it was 50, 60 years ago, right? 70 years ago. But typically back in the day, women led a more sedentary life where and their jobs weren't as physically demanding as a man's job, right? And I know I'm trying not to be sexist here, but it's just how it was. So that could be one reason that led to the loss of bone density in the older generation of women today. Another possible cause too is that pregnancy and childbirth, that when you go through childbirth and you deliver a baby, and the whole process itself requires so much on the body. It literally saps your body of like all these nutrients and all these vital essential components of your body to have a child. And some science says that you don't get that back until like a year or two after you've had that child, right? It takes you that long to recover. So I don't know if some of you have actually known women who've had multiple children and they actually lose their teeth. And it's because of that same reason, right? They lose a lot of the calcium, they lose a lot of nutrients, and they lose a lot of pretty much a whole bunch of other things in the body, right? So childbirth, sedentary life, all could lead to the potential makings of osteoporosis. And that's not to say that it's the only causes, but what exactly is going on with osteoporosis, right? So we know that, one, if we're dealing with older generation women, we could possibly perceive that the bones may be more brittle. And with older generations in general, bones become more brittle, right? So the problem with osteoporosis is the fact that it's more susceptible to fractures or injury or breaking. So in this case, we'd want to be very tempered, very reserved with our pressure with osteoporosis. Rheumatoid arthritis. So kind of the flip side of the arthritis coin, right? So we looked at osteoarthritis. And osteoarthritis, right, just the general wear and tear arthritis, is just, usually occurs through age and use. Rheumatoid arthritis is quite different. So rheumatoid arthritis is actually what we call an autoimmune disorder. Now, an autoimmune disorder is where your own immune system attacks your body or parts of your body as if it was like a foreign and invasive thing, right? It says, hey, you shouldn't be here, but it's like, what, I've been here all your life. And then it's like, get out of here, punk, right? And it starts beating it up. So rheumatoid arthritis specifically targets the joints themselves, the linings and synovial linings of the joints itself, most likely. So what happens is this just creates just a lot of erosion and reduction of the structures in the bones or in the joints themselves that allow for fluid movements. And so you just have this, and it can even warp the bones too, as you see in the picture there, warp the joints itself, and just creates all this painful movement, right? So rheumatoid arthritis will usually come in and out of what we call exasperation. So exasperation is where it's essentially flared up. So your rheumatism can be acting up, and then you could have just all this pain in your joints. And usually it starts from the extremities and up. So it starts usually in the hands and works its way up and stuff. But needless to say, if your client is in an exasperated state of rheumatoid arthritis, it's usually best to postpone the massage. And they're more than likely, if it's really exasperated anyways, they're probably going to be so discomforted that they wouldn't really want the massage that much anyways. But usually it's in your best interest, if they're in an exasperated state, that you postpone massage. But if they are just normal, right? Everything's feeling okay, but they just have rheumatoid arthritis anyways, massage is green lighted for the most part of rheumatoid arthritis. And then just being very careful and cautious working around those joints, as there might be pain and discomfort in those areas, especially with moving them. And there's our scoliosis. So scoliosis is what we call a lateral curvature, lateral to the side, or a sideways curvature of the spine. So instead of, if you're looking at the spine straight on like this, instead of being straight, it's all whoop, S to the side. So we call it an S curve. Now, there could be a single lateral curvature, or there could be two lateral curvatures. So it looks something like this, right? And we call that a double S curve, right? And again, scoliosis, a postural abnormality, right? You could try to break down the science on what muscles are tight and this, that, and the other, and pulling it in this direction and that and the other. But most likely, like, you're never going to get that crazy and detailed with your work. But if you are, just do your research. So again, our biggest issue and biggest concern is comfort of the client and bolstering them appropriately. So, if you look at the picture that's listed there, though, you can see where there would be tension in certain areas of the spine. So they might be complaining about pain in those specific spots. And you could just work those areas generally, in a sense, to relieve their pain and discomfort. Bolstering itself, usually it's not a problem when they lay face up, face down. So not a huge concern, unless they were maybe side lying, and then your concerns would be, trying to keep the body as neutral as possible. However, in some extreme cases of scoliosis, the spine can actually be turned and rotated too because of it. And so it's really just, talking and communicating with your client to make sure that they're the most comfortable that they can be while on your table. Spondylosis. So spondylosis, let's break that word down real quick. So spond, anytime you see the word spond, it almost looks like spine. Spond actually refers to the spine itself. And then osis, again, the condition of. So this is a condition of the spine. More specifically, it's basically arthritis in the spine. So it could be degenerative degenerations around certain joints of the spine. As you can see there, that's like the anterior bodies of the spine. So on and so forth, right? Basically, it's just arthritis in the spine, and it goes along with the same considerations we had for arthritis itself, which is just being mindful of the movements that we would produce at the joints. So, being careful of turning and moving their spine, as we really do that a whole lot, right? And just generally keeping your client comfortable. A sprain. Another big one here. Make sure you know how to differentiate a sprain versus a strain. So sprains, think like you sprain your ankle, and that's usually and well, not usually, but that is because of the ligament that you tore, right? So sprains are where we tear ligaments. Now, we'll see strains a little bit later in the muscular system, because strains are injuries to the muscle tissue or tendons. So think that strain, as in with a T in it, affects the tendons and muscles. Sprains, well, just ligaments, right? So in this case, if you have two conditions, sprains and strains, if you can just commit to remembering one, right? You know that sprains and strains exist, and they both affect muscles and tendons, or not both, and they would affect muscles, tendons, and ligaments, right? Well, just associate one category, right? Sprains, ligaments, sprains, ligaments, sprains, ligaments. So then all you have to do is like, well, it's asking me about a strain. Is it a sprain, which is a ligament? Nope. Then it's got to be the muscle and tendon. Is someone trying to ask someone? I hear a mic going off. Hello? Hello? I hear your dog. Heard you talk to it. Nope. That's it. Cool. All right. So sprains versus strains. Simple as that. Make sure you know the difference. It seems silly, but you'd be surprised how many people forget it. especially when it comes to test taking time. Let's go ahead and break it down a little bit further though. So when it comes to sprains and strains, we have grades of sprains and strains. We have grade 1, 2, and 3. So what are we going to do with our massage approach to strains and sprains? Well, one, a grade 1 sprain, you probably don't even know you have it. It's that mild, right? It might be a little sore. There's definitely some micro tearing, some minor tearing, right? But it's manageable. It's probably not causing you to have reduced function in the area, right? So think like if you've ever worked out really, really hard and you were sore for like a day or so after, that's kind of like, that's honestly even more extreme than even just a grade 1 sprain probably. So, grade 1's usually nothing serious. You're probably not even going to have many, if any, signs of inflammation. And then grade 2 is a very broad spectrum of sprain or strain. And this could be, tearing above the grade 1, where now you start to feel it. You definitely did a little something. You might got some minor signs of inflammation. And it might be, tender to the touch or tender to walk on or whatever, right? Upwards to where it's almost a grade 3 strain, right? Or sprain, where you have, pretty intense damage to the structure, to the ligament or to the muscle itself. And you definitely have signs of inflammation. You're definitely limping on there, right? And so, signs of inflammation would be the heat, swelling, redness, pain, of course, bruising in the area as well, post the strain, sprain, usually in the recovery stage. And you're definitely not walking around and moving on it very well. Then, of course, a grade 3 is usually like a near to complete separation or disruption of the structure. So you literally have just snapped that tendon, you pop that tendon off, you tore that ligament so hard that it's just hanging on by a feather, right? And so grade 3 strains and sprains, definitely you're not moving or walking on at all. You're definitely have lots of signs of inflammation, lots of bruising, lots of swelling, all that stuff. And it may require surgical intervention. So what do we do? Well, if it's pretty fresh, remember, so anytime we're dealing with acute injuries, we usually just leave the area alone, right? If they literally sprain the ankle, walk into your office right in the parking lot, well, hopefully you don't get sued. But 2, we're probably going to postpone the session if it's really that bad. But otherwise, just avoid the area. However, in some cases where, healing is starting to really take over, one, avoiding the area, but, lymphatic drainage, if you're trained on it, could be beneficial as you're just helping to flush and promote, healing mechanisms in the area. But otherwise, we generally leave them alone, sprains and strains. So local contraindication. Temporal mandibular joint disorders, also known as TMJD. So first off, what is the temporal mandibular joint? Well, that's your jaw joint. That's the jaw thing right here. The joint I've been moving all night, right? So wide range of possible causes and problems, which essentially just lead to pain and discomfort with moving the jaw. A lot of times, though, they can be related to muscles, right? And so, like your masseter, right? Your temporalis muscle, deeper muscles inside the jaw itself, like the pterygoid muscles, could all be causes of, potential TMJD. Then, of course, there's other issues, like grinding of teeth and all these other things. And then, just could be whole other stuff. Even sometimes even the SCM might even cause like referred pain to the jaw, and it almost feel like TMJD, right? So in many cases with TMJD, massage can be very beneficial, right? And that lost my train of thought. Anyways, working these muscles themselves, right? And so Florida is actually one of the best states to practice massage in, because we are actually allowed to work in the oral cavity, unless that's changed, and I'll have to double check, correct me if I'm wrong, but we can actually work in the oral cavity. Now, it's not just mean go stick your fingers in everybody's mouth, clearly just gross anyways. Make sure you glove up though. We can actually work the inside of the mouth to, alleviate TMJD. So your big go-tos are, especially working the masseter, essentially you can do a lot of pin and stretch where you just press in and just have your client depress and elevate the jaw, right? So, great instance for massage therapy to kind of come in and really help out with. But of course, if any time, like we said before, that your client's feeling pain and discomfort, especially with the massage, just leave it alone. And also, I would be reluctant to want to have my client face down in the headrest if it's really that bad. So I might stick with just straight supine work, maybe side lying at best, and then just avoid, the jaw as well. And I think that's going to do it for the skeletal system. Excellent. So we have the muscular system now. And I'll try to get through most of this before we end the session, but that took a lot of time. Whew, sorry. Anyways, so let's take a look at the functions of the muscular system, right? So one, movement, right? We already looked at the skeletal system and saw that, well, with the help of the muscles and the nerves, right, we pull and move these bones in certain ways that cause these movements. Well, the muscular system itself, right, is what pulls the bones into those directions, right? So they are what we call the pulleys. Posture maintenance. Well, our spine, right? If I take my good old buddy, Mr. Bones here, right, and try to just stand him up without that big old stick in his butt, he falls and collapses to the floor, right? So your bones themselves are not perfectly designed to be Jenga stacked together and stay in the position that they're in, right? Muscles are what's going to keep your muscles and ligaments and tendons are what's going to be keeping your body in position where it should be, right? So muscles are involved with maintaining your posture. And then lastly, the muscles, when they contract, produce a lot of energy, right? When we look at the deeper science of, breaking molecular bonds and releasing energy to cause muscle contraction and so on and so forth, right? It produces a lot of heat, right? And so they say, oh, you're cold? Do some jumping jacks, right? Trust me, you'll warm up. So heat production is also another functionality of the muscular system. So let's take a look at some of the pathologies. Our first one is what we call de Quervain Tenosynovitis, or as we could also call it, de Quervain syndrome. So what exactly is it? Well, first off, de Quervain, I'm pretty sure is just some guy who maybe researched this, I guess. I don't know. Go ahead and leave that in the comments of who de Quervain is. Anyways, let's break down tenosynovitis, right? We can definitely do something with that word. So remember, whenever we're looking at the anatomical words, we always want to break them down and we read them backwards, right? So we have itis, right? Inflammation. Syno, right? Synovial, right? We've seen that word before. Synovial referring to the joints and stuff like that. And teno, tendon, synovial, inflammation, right? So this is inflammation of the synovial membranes of a tendon. So let's break it down a little bit more, or we'll not break it down, but add detail to that, right? So tenosynovitis. inflammation of the tendon's synovial lining, or sheath, as it's called. So obviously, anytime we have inflammation somewhere, we're more than likely gonna have a little bit of pain and swelling and all this good stuff. Well, maybe not good, but So more specifically, what tendons? Well, it's most commonly these tendons right here, your extensor pollicis longus or brevis, right, of the wrist, lateral side of your wrist, right? And so this is usually caused by a lot of excessive movement of the wrist itself. So a lot of mechanics, especially with gripping and stuff like that. People, as it says there, playing golf or a racket sport, gripping a racket and things like that. All that good stuff that would cause this condition. So what do we do, right? Well, one, anytime you have, so this is what we call an overuse injury, right? Anytime we have an overuse injury, especially inflammation, we just need to let it heal, right? Just let nature do what nature does and just let it heal and just leave it alone, right? Now, of course, we might be palliative. We can loosely work the area if it's not like excessively inflamed and causing them pain. But otherwise, it's on their own part to get some relief, right? Stop doing what you're doing, right? Take a vacation from the activity, right? That's one of the biggest things, like carpal tunnel. So, fibromyalgia syndrome. A lot of people might have heard of this, might know someone with it, might have it, right? Fibromyalgia is certainly a very interesting condition, and in the realm of medicine, it's kind of like a catch-all condition. Like sometimes when you just have like unexplained pain and stuff and whatever, like your doctor is just like, yeah, it's fibromyalgia, whatever, I don't know. And like a lot of times I feel people are misdiagnosed with fibromyalgia. Like, oh, I came in, my shoulder's been hurting for the last couple weeks. Probably because you got fibromyalgia, but you really probably don't, right? And you just got this misdiagnosis, or maybe you used Dr. Google and you came across fibromyalgia and that's what you said. Because I've literally had so many people write on their health intake forms that they had fibromyalgia and then have like no symptoms of fibromyalgia. So what exactly is fibromyalgia? Well, one, there is no known cause for fibromyalgia. It's just it just came about, right? And I personally think it's a lot of stress related concern, but that's neither here nor there. But it causes pain, especially can be very intense pain, right? Usually body wide, especially. So if we break the word down, fibrous tissues, myo is muscle, algia is pain. So this is pain in the muscles, in the connective tissue, in the fibrous connective tissues, right? But with no known cause. So if you've actually known someone with true fibromyalgia, like it hurts to be alive. Like anything, any movement, like wearing the shirt on your back would hurt. Like it hurts to get in the bathtub full of water. Like life is just excruciating and terrible and painful, which is why like anyone who's ever gotten a massage that I've seen right now fibromyalgia, I'm like, oh, well, what's your tolerance of pain? And they're like, oh, I like deep pressure. Like, you don't have fibromyalgia. Get out of here. But let's break it down a little bit, so there's, in my best experience as I've consulted with other experts on fibromyalgia, the fact that very, very light stimuli can cause the reaction, the painful signals. In some cases, it may actually be beneficial to apply a firmer pressure, because in some instances, based off of certain neurological laws, that applying a heavier pressure actually reduces the amount of neural activity that would be sent, right? So think like, well, if I do this very lightly on my arm, right, I feel like all this tingling and buzzing sensation, right, going to my nervous system, right? You get a tickle, right? But if I apply steep, sustained pressure, there's a lot less signals being transmitted, right? So in some cases, a firm pressure may be beneficial for certain fibromyalgia clients, but I'm putting an asterisk on that real quick. And there are certain beliefs of the direction in which your strokes go, especially on the back, going from like the caudal region to the cephalic region being much more better because of sending signals and something. But anyways, right? So back to the pressure level, right? I mean, if it honestly just hurts to even be within inches of the client, if laying on a table is just terribly painful for the client, you just really need to communicate with them with their comfort levels and just approach everything very slowly, cautiously, and just really have that communication between you and your client for their comfort level and what you're doing, right? And maybe try with a moderate, but light, firm pressure, and just start adjusting and seeing what they are comfortable with. Yeah, fibromyalgia is a pretty big one. I'm pretty sure that the daytime instructor, Mr. Garcia, has researched this a lot. So if you have any deeper questions, and I'm sure he has more knowledge on it than I do, and this is a big population that you really care to learn more about, by all means, reach out. Myofascial pain syndrome, almost the same as fibromyalgia, but we have clear definitions of why it's there. So typically this is overuse of muscles, right? That typically leads to like trigger points in the area, or just general soreness in the area, right? And tender muscles in general. So massage and myofascial pain syndrome, go hand in hand. It's pretty much like the #1 treatment for myofascial pain syndrome. I mean, as you might see it as listed there, this is like dry needling, injections and stuff like that, but whatever. Again, break the words down. Myo, muscle, fascial, fascia, muscle, fascia, connective tissue, pain syndrome, right? Osgood-Schlatter disease. So if you look at that picture, what's called the tibial tuberosity is overdeveloped. So this could happen because you're up and down on your knees a lot, or it just grows excessively regardless, or whatever, right? Which leads to the excessive development of the tibial tuberosity, which if you grab my bones, so if you look, it's this bump right here. If that starts to grow out more, well, what attaches right here is the patellar tendon, the quadriceps tendon, right? And so it causes irritation into that tendon, and then inflammation and just pain, typically in the anterior part of the knee. So massage could be helpful in just easing the pain, but nothing else. Plantar fasciitis. Ooh, oh man, this one can take a while. So first off, what is the plantar fascia? So if we break it down, plantar, bottom of the foot, right? Fascia, connective tissue. Itis, inflammation of the connective tissue on the bottom of the foot. So what are the causes of plantar fasciitis? Well, typically, first and foremost, it's overuse, right? Most people you commonly see with plantar fasciitis are runners, or people who stand a lot, or whatever, right? So it's typically an overuse injury that leads to just the inflammation and pain on the bottom of the foot. However, it's not the only cause. Some other causes could be heel spurs. So a piece of the bone, a bone spur, right, could be developed right there on the calcaneus and actually presses into the plantar fascia, which then causes irritation as you move. So in the case of that heel spur, massage, it's only good if or only good for reducing pain and suffering, right? Because it's still going to be there no matter what until whatever other intervention might come along to reduce the heel spur, right? However, if it's the overused version of plantar fasciitis, right, we can definitely come in and shine a little bit harder with that. So how? What do we do? Well, pretty much, you just work the area. But let me give you more details, especially personal experience. I have fixed, we say that loosely in air quotes, don't quote me on that, right? I have really elevated many people's discomfort of plantar fasciitis with cupping. I love cupping, especially I'll cup the bottom of the foot, right? Especially, and just let those cups sit on there for a good minute, and then I just massage them out. And then especially don't forget the calf muscles role in, the interplay of the foot, because like that same continuum of Achilles tendon into the calcaneal tendon there, into the plantar fascia, into the plantar fascia, it's all pretty well interconnected. So don't rule out the necessity of working the calf muscles as well. So typically I would actually, I would cup the foot and then work the calf. And then I would switch my cups from the foot to the calf and work the foot. And then just work the entire structure afterwards, after all. Especially, you could even work the calcaneal tendon, with like bending on the calcaneal tendon, bending in like little light petrissage on the calcaneal tendon works really well. And I guarantee you works amazing in the sense of massage. Other methods, as most doctors would say, is to freeze the water bottle and roll it on your foot. So, okay, cool, right? Freeze the water bottle, which is ice to reduce the inflammation, and then rolling it on your foot is massage. So, hey, if you've got ice, put it on the bottom of the foot and massage that foot with some ice. We can do ice massage if you have it for you. But really the best thing to do, especially if they're a runner and have plantar fasciitis, stop running. I don't run. I don't like running. I think it's for the birds, man. I'm going to fly. Okay. So get out of here. Shin splints. So shin splints, well, good thing I got this guy right here. The muscles on your shin, aka the anterior surface of your leg, the crural region, are namely tibialis anterior, extensor digitorum longus, extensor hallucis longus, and maybe several others, and the peroneal muscles maybe over there. But anyways, so these muscles are involved with dorsiflexion of the foot, right? And so typically, as we run, right, we're lifting that back of the foot, top of the foot up, and all this stuff, and whatever, and all that good stuff, right? And it's causing the excessive use, basically DOMS, right? Like the sore muscles in the shins, which in many cases where it's super excessive leads to micro tearing or even larger tearing of those muscles themselves, right? So obviously the biggest onset is like running, usually the biggest example of shin splints. And so your best elevations is, light massage, just flushing the area out, within reason if it's not, too damaged or inflamed. And, of course, just stop, just let it heal on its own, right? But, shin splints can be so severe that it can cause a lot of other problems. Like I actually had a friend, he joined the military, and with all the running with 80 pounds of gear on, caused such severe shin splints that his legs were about to break. Like he had shin splints to the point where he had hairline fractures in the lower leg. And it can even cause other major complications like other leg issues like compartment syndrome and a bunch of other stuff. So, but anyways, shin splints itself, normally and in most cases, it's nothing of a major concern. We can, be very general and easy on the area and just massage it. And then if need be, avoid the area altogether. A strain. Well, we pretty much already covered that in the previous slide with the sprains. So just remember, strains are the injuries to the muscle and tendons, or there you go. And there's 3 grades, grade 1, 2, and 3. And massage can be helpful in recovery if you consider all the other factors, such as, how much damage is there, how far out post injury are you, and, things of that nature. So, rewind the video back to the sprains if you need to and take a look. Tension headaches. So in the world of headaches, there are 2 major ones that massage therapists concern themselves with, which are tension headaches, of course, and then migraine headaches. So migraine headaches are caused because of a lot of other things. And a lot of the causes of migraine headaches, like massage can't control. So massage itself for migraine headaches is more palliative. We can, massage someone and they feel a little bit better, and they might actually reduce their headache to a good extent, but it's never going to completely get rid of them or solve the problem for migraine headaches. But tension headaches, well, are caused by tension in a muscle. So typically, basically any muscle in the neck, in the upper body neck area, can cause tension headaches, especially if it attaches near or around the skull. So your common muscles would be like the SCM, trapezius, levator scapula, scalenes, deeper muscles in the anterior neck, like the hyoids and all that, your suboccipital muscles, your splenius capitis muscles. I'm sorry, am I listing too many for you? But anyways, lots of muscles could potentially be the cause of tension headaches, and massaging them is pretty much your best way. So most commonly, we talk about what's called a trigger point, right? That is present in the muscle itself, which I think trigger points aren't listed as a concern there. But anyways, the trigger point is an area in a muscle where there's hyperirritability and usually causes referred pain, which referred pain means that if I press here, I feel it here. And so, we can work out these little areas where there's that little localized, hyperirritability, and hopefully alleviate, the tension headaches. So a lot of times, tension headaches, people get just staring at a screen, being in a certain position for too long, so on and so forth. So pretty much tension headaches and massage is bread and butter, just working, muscles of the neck and shoulders, muscles of the face, even don't forget muscles of the face. So, a good head, a good scalp, face, neck and shoulder massage. I mean, your general routine for that would more than likely deal with the tension headache. So go for it. Excuse me. Torticolis. So I don't know, for some reason, when I think of torticolis, I think like a turtle, and he's like, Grr. And that's because I have this position in my neck, right? So what is torticolis? Well, torticolis, again, is a bit of a postural abnormality here, where an involuntary contracture of the SCM, your sternocleidomastoid, causes your head to be turned towards the side, laterally flexed and turned to the opposite side, and even the chin kind of tucked, right? And in this position. So this actually can be caused for several reasons. And in some cases too, even children develop this. I think they call it wry neck, where the child's head is turned to the side. But for the most part, if there's no underlying major concern like, infection or, major systemic inflammation or, a major injury such as the next slide that we'll see, like whiplash, torticolis, we just work the SCM, it's very manageable with massage. So, massage is usually a good green light, depending on if there's other pre-existing factors and concerns that would, cause massage not to be. As a matter of fact, I had torticolis too, and I didn't even know. And it was caused because of automotive injuries that I had sustained, and I didn't even know. And one day I just woke up and I was like this, and I couldn't even turn my head. It hurt so bad. And so to this day, I still like work my SCM and release my SCM. So yeah, that's also the other reason why my headaches too, Amber, if you're listening. Whiplash. So I think that's sweet. All right, perfect. We're gonna finish the slide and we're gonna call it for the night. That's 2 systems down. It's gonna be great. All right, so whiplash. We can go into quite a bit of detail here. So first off, we all are pretty well aware of what whiplash is, right? It's the sudden violent movement of the head and neck, most commonly because of an automotive accident or whatever. But there's plenty of other things that could be contributing to whiplash, right? You could, be riding on some other vehicle. You could have, fallen suddenly and whipped your head, or, tripped or whatever, right? Any sudden violent movement could cause whiplash in the neck. So if you're trying to break down what muscles might be or what structures might be involved or injured, well, it just depends on the nature of how the head moved, right? So if, for instance, let's say I was parked at a light and someone rear ends me, right? So immediately I tilt back like this. So very well, I could have torn or have damage to anterior structures of the neck. But there's also that rebound effect where now I shoot forward, and now I could also have potentially injuries to the back of the neck, the posterior neck. If I get T-boned, if I'm T-boned on the driver's side, well, boom, now lateral side here, and then rebound lateral side here, right? So sometimes if you have clients who come in and they say they have whiplash or automotive accidents, sometimes just a brief question of like, well, can you explain the accident? Like, where were you hit? How did you hit or get hit, right? Could help you understand like where in the neck you might want to focus more. But let's talk about the actual injury and especially the immediacy of the injury. So one, unless you're working at like a medical office or a chiropractic office or, like a rehab facility, physical therapy facility, you'd probably want to steer clear of actually working with whiplash within the first month, right? Because one, especially like, let's say that, and this is very common, a client, comes in, books a massage because their neck's hurting, and then on their paperwork says, they just got in an accident 3-4 days ago, maybe even 5 days ago, right? A week ago. Well, there could be some damage there, and that's why you're feeling the pain. It wouldn't be uncommon. Did you go and get checked out? Did you go and get scans to see if there's any tissue damage, right? If no, then you definitely should, right? I would more than likely request that my client goes and gets checked out and make sure that there's nothing seriously wrong, right? Because it wasn't until, especially for my automotive accident giving me torticolis, it wasn't actually until like several months later that I actually started to really have problems because of the accident. So you never know at what point you could have problems, right? Something could have happened and it snowballs into something later on if you don't, take care of it immediately. So, making sure that your client really gets checked out for something is very important, especially in a case like this. Also, let's say that, and we actually just had someone come to the school, and I had to turn their massage down. They came to the school and they had an automotive accident, and pain and discomfort in the neck, and they were trying to get a massage to help with the pain. And I told them, I was like, and I even asked, I was like, are you pursuing, legal measures with this accident? And they were, right? And so without an actual referral from another health practitioner to actually receive the massage, right, we could be at a we could really disadvantage someone's lawsuit, because let's say massage was the miracle cure, right? And all of a sudden they just got so much better after the massage that now there's like, oh, well, what's your problem? And they just lose their lawsuit because of stuff like that, right? Or the fact that they got a massage and, we didn't document properly the restrictions that they might have had, the range of motion restrictions they might have had, the pain level, stuff that they might have had, which we could have received that from the other healthcare practitioner if we were networking like that and had document release, right? And then we didn't document even further, what margins of benefit or what we even did to a minor degree. So this is why also your documentation is so important too, because when legal matter, like documentation, it's not necessarily like, oh, I just need to read it so I know what I did with the client last time. No, it's more of a legal matter than mostly anything, right? So, your like client comes in and they're trying to, it's like, and trust me, I've had places that I've worked get subpoenaed for a client's medical records because they were pursuing a lawsuit because of an injury. And matter of fact, I even had a client who, like, our business got subpoenaed, and then like I saw him later. It's like, hey, I hope everything went good with the lawsuit. He's like, how'd you know about that? And I was like, oh, yeah, we got subpoenaed to release your information. And he's like, what? That's crazy, because it had nothing to do with massage, right? He didn't even say that he got massage, but the lawyers knew that, like looked at all this stuff, and they're like, lawyers, they'll dig, right? And they found like all the massages he got. They wanted all this information, this, that. That's crazy, right? So, in a legal sense, yeah, wait it out. As a matter of fact, in some spas, they have, like, if you've been in an automotive accident, they won't even let you book for like 6 months, especially without, like a doctor's release, so, with Whiplash, be very careful in the sense of legal matters, but still, even for your client's safety, right? Because you never know what could be really going on deep in that area, right? You could have some sort of dislodgement and, minor displacement of vertebrae, compresses on the vertebral artery and things like this. And, there's a lot of stuff, right? So, try not to play around with it, but cool. We're going to leave it off to the lymphatic system, which, whoo, man, this might be a 3-parter. Sometimes I ramble on too much. I just love the sound of my own voice. I hope you guys love it too. So if there are any questions on anything we've covered so far, I'll leave the floor open, but we can go ahead and turn the recording off. Amber, if you're listening.